Grandrounds. He distinguished himself while he was here as being an outstanding resident, gave a lot of really excellent presentations from this very podium, and then has gone on to do a fellowship or a residency program up at Shock Trauma in Baltimore, Maryland Shock Trauma Unit. Did postgraduate training there, and then now is a faculty member over at Charlotte in a really excellent surgery program over there. So we're really happy to have Kyle Cunningham back. He is from Ohio originally, and we were able to recruit him down here as an intern, start out, and we're happy he was here, and we're happy to welcome him back. He's like a member of the family. Kyle, we'll look forward to hearing from you about your presentation this morning.
Thank you, Dr. Burns. Thank you, everybody, for having me back. I'm going to talk on a subject. I gave a talk on a similar subject related to a different part of a different aspect of surgery last summer, and I looked up at one point, and I think about everybody was asleep. So I revamped things a bit, and hopefully that won't happen today. I'm going to try to stay out of the weeds, out of the numbers as much as we did the first time around, but I think it's an important subject to go over because it's really going to impact your future quite a bit, specifically within surgery. So I'm talking about the crossroads of public health and surgery, but specific quality and how you can deliver on that. As always, I have no financial disclosures, no conflicts of interest, other than as we go through discussing the ACP fellowship. I currently serve as their medical director for that. So I always like to start out with a quote from someone that really kind of embodies quality and process improvement for me, and that's W. Edwards Deming. But it says, it's not necessary to change because survival is not mandatory. And I think it really drives the business climate surrounding medicine right now. In my talk, I'll go a little bit two. I have 3 key points. I'll keep driving these and working these in as we go. And these are really objectives for my talk, too. So we're going to learn a little bit about the value equation, define it. But keep in mind that the value equation drives change in our marketplace. And then we'll talk a little bit about some disruptors that have come up over the last, I would say, decade, and how those can either shortcut and make your life easier or short-circuit it and make things a nightmare. And then finally, we'll just discuss a little bit how you should know your organization's strategy, where your organization is going and why that's important to your day-to-day life. So why public health? And what is public health? Well, the American Public Health Association defines it as protection and promotion of the health of people in the communities where they live, learn, work, and play. And I always thought that sounded kind of generic, so I like to see it used in a paragraph. And they go on further to describe it as a way to track disease outbreaks, a la Jon Snow, prevent injuries. They go into advocacy with speaking out, and ways to stay healthy, giving science-based solutions to the problem. And I think, by and large, public health has started to morph more from general well-being, what you think of your county health department doing, into more of a bastion of science for evidence-based practice and epidemiology. So acute care surgery, how do we come on that? I think this institution, more than most, understands the underpinnings of that with a joint practice between trauma, critical care, and emergency general surgery. It's been in practice here for a long time. When I think of it, I think of these 2 gentlemen and for different reasons. On your right is Dr. Britt, who a lot of times is termed with coining the phrase acute care surgery and writing about it in books and papers and really championing the concept through Virginia and along the coast. And on your left is Dr. Richardson, who I respect quite a bit for his opinions on things, and I think routinely I've seen get up at meetings, including at East 2 years ago, and gave the keynote address about how acute care surgery is really what general surgery should be. And that's a well-rounded practicing physician who really provides a specific level care, but can provide anything at any time that you need it. So I go on, and I think of 4 things that have really led me to get to kind of the point where I am in my career. And I really come back to 4 defining lines. And the first is I was finishing medical school on the interview trail, kind of mid to end of the interview trail. Come to Chattanooga. I'd heard some wonderful things about the program, kind of all the normal stuff people will feed you as you go. And then I ran into these two people at the get to know you dinner the night before. And on your left is Brad Thomas. And he said, "Did you know we have a surgery critical care fellowship?" And despite trying to do my research on the program, no, I didn't know that the program was actually integrated here. And we talked a lot about that, and I decided that sounded pretty interesting. The rest is history. Came here, had the chance to work with Brad for a few years, and thought, man, it'd be really cool to have a partner like that someday in practice. You just really enjoy the same things, respect for the patient, really approach your practice the same way. So residency goes on, and pretty soon I have my meeting, and I'm sitting down for my annual meeting, fourth year, with Dr. Kofer, who's my program director. And I'm expecting the standard, hey, how you doing? What's going on? I saw your ABSATE scores, standard meet with your advisor stuff. And finally, he just kind of stops and he sets everything down and he looks me right in the eye. He says, what are you going to do with your life, Cunningham? And he really wanted to know what my plans were because he knew I wanted to do a critical care fellowship. But he really wanted me to define what I want out of my practice and where I want to go with that. And for me, that was defining. And he actually used the phrase, do you want to go and practice in a community setting where you can be your community doc, like back home in southeastern Ohio? Or do you want to be and he said, big dog trauma surgeon. And I thought about it a lot, and I figured, well, I think that probably leaves the most option open, so that's probably where I should go. And at that point, I think I realized I was passionate enough about the craft. So from there, I moved on to Maryland, up to shock trauma for a few years. And at the end of my first year, you're coming about 2/3 of the way through your fellowship year. It's time to start looking for jobs. And the boss pulls me in. He sits me down and says, where do you want to work? He's got a lot of pull, has a lot of connections. You can look at job boards, but it's not the same as actually talking to Dr. Scalea. He tends to know the ins on where the real job is going to be. He asked, where do you want to work? So we talked about it and really determined that the question wasn't so much where I wanted to work, so much as what I wanted to do. And I had an idea for him after talking to a few of my mentors that I really wanted some more background in epidemiology and outcomes research. I thought the field was trending that direction, and that's where I needed to be. So he said, well, there's an opportunity. You could stay here. I'd keep you on staff for a year, and you could go over to Hopkins, work with Ellen McKinsey for a year in injury prevention, public policy, and really specialize in outcomes research. And being Dr. Scalea, he's going to find a way to make that happen. And that's exactly what happened. So finally, I found myself in the department of Ellen McKinsey. I've got her picture up here. She's now a dean of the School of Public Health at Johns Hopkins. And you had your capstone project. I went in, kind of told her what I wanted to do. It's your version of a thesis there. And she says, I have some people I'd like you to meet. And she introduced me to Dr. Stewart and Dr. Winchell. And Dr. Stewart was, at the time, chair of the Committee on Trauma, and Dr. Winchell was a director for systems evaluation for the college. Excellent people, very knowledgeable people, and specifically very knowledgeable about what I wanted to do. At the time, things were in crisis mode in Florida in terms of determining how many trauma centers you need, how you provide for the care of the population. So in order to do that, they came up with this, which is a needs-based assessment in trauma systems, or MBATS as it's called. And several of you have probably heard about MBATS. It's designed as a way to assess the population's need for a new trauma center. Private hospital systems are sprouting up hospitals right and left, opening up level 2s, charging trauma activation fees, and more or less driving down volume at some of the level 1s. And it got to be a question of whether or not they were going to be able to provide adequate care in a scaled economy after dividing up essentially the customer base as thin as they did. So they really looked for a way they could pull everything together, not alienate any of the private institutions, because they were necessary in the market as well. They're providing good care. It's just a matter of how do you determine the need for that through the eyes of the population. So basing it on outcomes research, things they knew about volumes in the past, about minimum threshold, transport times, they really sit down to come up with the criteria to determine through the eyes of the population what that means. And that's where it really started to cross over for me into the public health realm, to where more high-end tools such as GIS mapping, transport times, census, and demography started to come into a practice that for me was ATLS driven prior to this. So again, the value equation will drive change. Disruptors can shortcut or short circuit, and you need to know your organization's strategy. So the value equation, how does all this fit together? Well, we're continually asked to provide increased value for anything, whether it's for our patients, for our health systems, for our communities. And that's defined as benefit over the cost. If you're in an engineering background, it's Ohm's law still. Your potential benefit over your resistance, being your cost, is going to equal your flow, which is your value, and ultimately your business or your hospital system is concerned about revenue flow coming in. You're concerned about flow of good care going out to your patients. So it starts to morph a little bit, and it becomes this, where you can increase value by adding increased service or increased business line, or add increased quality for your patient. And then ultimately, people right now are trying to attack decreased cost. By reducing the denominator, they'll increase their outputs. So then they tie in more depending on what area you're into. And it starts to get pretty complicated after a while if you start tying into everything that goes into outcomes and cost, whether it be quality, increased efficacy of procedures, are you increasing safety at your institution? People at the bottom start wanting to know about head counts and tallies and how many people and widgets does it fit in and out. And most importantly, nowadays people are talking about dollars. How much is this all going to cost? So if we started looking at different health policy things, the largest one to come across lately is the ACA. So my first big foray into big data once I got out was shown here, and this is something we presented at East from our institution. The challenge we were facing was that ACA was enacted in 2010 with three aims: to make health insurance more affordable for everybody, and they wanted to do that through expanding Medicaid coverage. And finally, they really wanted to support some innovative ideas to decrease the cost and lower costs, so put cost controls on the system. To date, 19 states have not expanded. Tennessee is one of those. Our medical center sits right on the border between this little notch between South Carolina and North Carolina. And we originally started this idea thinking that North Carolina would likely adopt expansion that was probably just enough of a division between political parties and factions, and the way the demographic was set up in North Carolina, it would probably accept it at the time. Even the Republican governor was discussing this, so we put our project in place to say, listen, we're going to capture and go head-to-head. South Carolina had expanded, North Carolina did not. What's that mean for our patients in terms of length of stay, discharge disposition, mortality, costs incurred, reimbursements from the medical center? Well, fortunately or unfortunately, however you might view it, North Carolina did not expand as well. So we really ended up with an observational study looking at what it has meant before and after, and a pre-post study for our patients. Well, here's a payer mix difference. And as you can see on the left-hand side, blue is pre, red is post. Medicaid is in blue on the far left. And we saw a drastic decrease in our Medicaid patients, in our Medicaid population. In our area, believe it or not, saw just a marginal increase in self-pay. And we were told that the sky was going to fall if you didn't expand. You're going to have all these uninsured people. And this is something we still haven't really sorted out, other than our specific center has seen a lot of growth in the area, and you see an influx of people coming in with paying jobs and insurance, which is what we saw in our study. We had actually a huge increase in the number of commercially insured patients pre and post those 3 years. And the other thing we have not been able to explain yet as well is why we had such a decrease in our Medicaid population. We didn't change enrollment status. We didn't change our emergency enrollment procedures over the course of this time frame. And we saw a pretty significant decrease in terms of payers for Medicaid. We went from 24% all the way down to 16% of our population base. In the trauma population, this is pretty significant. Most people run about a fifth of their patients are running Medicaid, which operates at a loss. Which brings me to my next point, why this is important for our system. Our median charges for these patients went up almost 30%. So we went from $24,000 to about $32,000 as a median charge that we billed out to every patient that came through. Now this gets changed depending on what payer you have and how your contracts are written. You don't actually see this, but I think it's a better surrogate of across the board what you're seeing and what you're charging out in terms of care that you provide. And on this chart, you have this huge hump here, that you have something in place that was supposed to have been a cost control, and you saw a massive takeoff afterwards in terms of your charges going out or what we're passing on to our patients or their payers. And there are two things on here that I think are noteworthy, aside from the fact that the cost control or presumed cost control didn't work. And that's at the bottom, that you still have an increasing difference between what it's costing you to provide care for a segment of the population, and this is a segment that is often disadvantaged to start with, and what you reimburse for providing care for those patients. And it's actually increasing to the point to where you saw in the final quarters of 2016, the crossover effect has finally happened for us in terms of all comers, that our income no longer meets what our costs are for providing the patients. So suddenly you're operating a loss, even though you're operating in a very affluent area. So again, that's just one aspect of the trauma. You can buttress that by buttressing your practice either with critical care, an elective general surgery practice. The system can eat that cost in other ways if they can find a way to make that work. Decrease length of stay and backfill. There are different ways to do, but it's really difficult to apply the value equation to acute care surgery because your practice is so heterogeneous, your safety net practice, and your value is actually defined by what you provide to other services on your critical care arm. How are you providing support to your transplant service, which is a huge revenue boom for the hospital? Your HBB service, we're a HBB center in Charlotte, so they get really aggressive with a lot of the care they provide, and most of their patients will require ICU care afterwards. So we said, everybody said, you need to improve the process. You need to drive down your cost. So how did process improvement move into healthcare? Well, just as we discussed, it's a growing segment of the population. It's a growing segment of the economy. It's now, as of 2015 totals, we're approaching 20% of GDP going to healthcare. So most importantly, we want to offer our patients better care. At the end of the day, you want to see better outcomes. And when I say outcomes, people are talking about mortality, return to work, functional status at 6 months. And that's, to me, what really matters in our patient population. And unfortunately, we're not seeing a huge improvement in those areas as well. So I put up the Deming quote at the start. Most people associate Deming with his process engineering. He was an engineer, was a management consultant, ultimately got hired away and went to work in Japan. And a lot of the Japanese system you see with lean processing is actually his brainchild through the years and continuous process improvement. He was really big on the PDSA cycle. So plan, do, study, act, and then, of course, lean processing, which we've attempted to put in as well. And the experiment he always used to illustrate process control in the manufacturing side was what he called the red bead experiment. And if you've never actually watched Deming do the red bead experiment, you should take a little bit of time tonight, instead of watching a television show or something else, get online, just Google, pull up on YouTube, however you can, to watch Deming's red bead experiment, because his explanation is infinitely better, and he's a very entertaining gentleman to start with. But essentially, he has a standard experiment he will do where he has you pour the beads, and it's a very regimented pattern. Hold the thing at a 30-degree angle, pour the beads from the corner into the second bin. It will mix the beads heterogeneously. You dip the plate in at a 45-degree angle, completely filling it. You shake as you remove. You hold it out flat, and the counter will count the beads for you. And the whole purpose is to not get any red beads. You consider red beads to be defects. And the white beads are what they're wanting to make. So those are good widgets or better patient outcomes, however you want to define it. And then they kept track of this, and he would put up a chart for how they drew. So I threw some people you might recognize up on here, and we'll say these are our trauma cases we do, and for every 100 trauma cases we did, we're looking at our poor outcomes. So you can see our round one we do. So say year one, I had 10, Dr. Maxwell had 8, Dr. Dart's 11, Dr. He had 7 defects that year. Total of 36 defects we had over the course of the year, 36 bad outcomes. So we say, all right, we're going to track this again next year. We're going to see if this trends out. So we had pretty similar numbers the next year in round 2. Well, round 3 comes around, And we say, well, listen, we're going to start taking the outliers, and you're going to be out of here. You're not going to participate. We're not getting reimbursed. However you want to define it, you're taken out of the equation. So I go away. I clearly had the worst outcomes across the board, and we defined it, and I'm gone. So again, the next year, they randomly come up with Dr. Maxwell had 5 poor outcomes, Dr. Dart had 10, and Dr. Mehy had 15 for 30. And if you look, going back, they have actually per capita had worse outcomes they did the previous year after removing someone that was the weakest link there. And then, interestingly, the last time around, if you look at a lot of process data, what happens here? Does anyone have any guesses what happened here? Yeah, so they fudged their numbers, right? Because you have the same process, you still didn't allow any control change. You see something drastically drop off. It was forcing people in process engineering to redefine what they do. And you'll see this. To me, one of the best examples is going off the fellowship. They're looking at CAUTI rates. And the urinary tract infection rate at one of the flagship ICUs in the country was sky high. It was one of the worst centers in the entire country. So they revamped the way they screened for urinary tract infections. And after that, they saw the largest improvement in the country, having one of the lowest rates of urinary tract infections present. And they hadn't done anything to treat the patients any different. They hadn't done anything to treat the infections when they occurred any different. All they had done was define how they were surveilling for these. So that shows the shortcomings of applying process controls to healthcare. It doesn't always translate over to widgets because patients aren't widgets. So again, rigid instructions, control limits, and they had data. And we start to stem into big data off of this. But modern ACS practice is full of red beads. You have night call, you have emergency patients, you have patients that are the sickest patients around and require ICU level care that you're going to need to provide. So the real question is, can you build a practice or a customer for red beads? And I think it's where you really see the value of ACS crop up. That Dr. Richardson would say, listen, this is not necessarily anything new. This is something we've been doing all along, but because of trends with burnout or trends with lifestyle, people tend not to want to do that work anymore. So it's created a gap in care that suddenly there's a business opportunity there as well, or an opportunity to jump in and provide care for these patients. So the promise of big data, you see it everywhere right now. And this is exactly what we're doing, and I would argue that's a fault of many of these institutions. Several, such as PCORI, are really good at comparing interventions head-to-head. So they're looking for a better outcome, and comparing 2 interventions to deliver a better quality product in the care that you provide. There are other things, such as TQIP, that let you help compare what you do to other institutions, but it really just defines the problem. So instead of coming in and helping you solve a problem, they're really ranking and measuring you on it. So you need to be careful with some of these programs that if, say, my director would have come to me and say, hey, our geriatric mortality is sky high compared to everywhere else, that's great. It defines that we may have a problem. But to say we're going to come in and fix it and expect that number to be down next year without doing anything different is not going to pan out for us. So along comes some disruptors. What do you do with the emergency night care problem? Well, one way to add value, Maryland, they opened up the critical care resuscitation unit. And I know several of the staff have been able to come up and tour that. But essentially, they realized there was this shortcoming for patients with non-traumatic time-sensitive illnesses and needing transfer. And the transfer times they were too high. They were sitting at their outside facility, waiting on a bed to open up at University of Maryland. And ultimately, they were having poor outcomes. So what they did is they adjusted, and they opened up this unit, a 6-bed unit, that accepted people, just like an ER, only for ICU patients, patients on the ventilator, patients that need to be cannulated for ECMO, patients that you think might be a rupture that need to come, patients that need to come for emergent surgery that they can come in and get pre-op while the team's assembling. So they opened this up, and to their surprise, they saw a 3-to-1 to 5-to-1 return on investment. The difference was it wasn't on this unit itself. If you looked at the balance sheet, this unit lost millions of dollars. They were $1 million to $3 million a year to operating. Very expensive unit, very expensive way they need to staff it out, both with advanced providers and with physicians around the clock. Heavy equipment volume. This is essentially the front-end care for an ICU. But if they looked at the back end, their decreased length of stay, their placement in the appropriate ICU, the appropriate service, their time to the OR was all improved to the point to where they were seeing a 3-to-1 to 5-to-1 return on investment if they look at the increased revenues due to those patients applied across the entire system. So administration just ate this up. So from Maryland, that was one example of what I saw that I thought really provided some interesting value. The next step is really advanced care providers, NPs, PAs that would come in. You might ask, what's a nurse practitioner? I think here at this institution, you all know very well, certainly very integrated here, and has been for a long time. I didn't include in this talk anything with the practice of red shirts here, because I think this is something that this institution has been a pioneer with. Could probably give the talk themselves on just red shirts and the value they provide, both to care of patients, but also to resident education and staff support. It's incredible. So I went for my first job interview. I sat down, and I wasn't expecting to sit down with their whole version of the equivalent of red shirts there also practices standard care. Whether it be in ICU, they're supportive on the surgical services, but it's a group of about 20 people. And that was my second interview room. I went in, had a group interview with the entire group. And I didn't realize at the time that it was that involved of a practice at Carolinas. And they said that they had grown so exponentially. The population of Charlotte has doubled over the last 20 years. They can't get any residents to cover everything. There's this huge shortcoming of house staff. It's expensive to hire in a bunch of physicians to provide the same care. So what they can do is try to push things farther for each physician and what they have to offer, and they've really fully integrated ACPs into their practice. So how many NP programs exist in the U.S. to train all these people? There's about 350, and it's a business opportunity for the schools. They're getting tuition for people to come in to pay to get the degrees and a promise of a job on the back end. No different than any other discipline. The difference between training programs for NPs and for doctors as you go through is that physicians have to go out and you have to practice in residency, and those numbers are capped. So there's a hard cap on the back end. You can't blow up the number exponentially of medical school training positions, because when you finish, there won't be anywhere to go to continue your training. That's not necessarily the case for NPs, and it's created a bit of a problem. So Carolinas came up with something new here. They said, well, listen, the shortcomings for ACPs really come in terms of training once you get out for specially specific training, ongoing certification or continuing education, by and large, doesn't exist in the way it does in the medical community. Integration into the service in terms of caps and restrictions on your practice and how you're going to balance that. And then finally, for funding, they actually were concerned at the time they weren't going to be paid as well as they were. They thought, gosh, we're not going to make anything over what a bedside nurse was at the time, despite getting an advanced degree and having advanced practice skills. How are we going to start working this? So they want a lobbying body to help them on that end too. So they wrote it up, and they really came up with something novel at the time. So this is Center for Advanced Practice Fellowship they opened up. And you can see that actually they wrote it up, and Dennis Taylor heads up that entire group. But a strategic approach for developing advanced practice workforce. So what they did was they designed essentially a residency program, or a one-year residency, they were calling it a fellowship program, for NP graduates to come in. So people have done clinical practice there, or their clinical rotations through NP school will come back in. They do a single year where they do specialty tracks specific to certain business lines. So we have 2 surgery critical care ACP fellows on staff with us at all times, and they rotate through all the different services that acute care surgery provides support for, much like you think of an internship would coming in. And then after that, they've got a year under the belt, some clinical experience that they've been proctored both by physicians and by peer ACPs, and they're really ready to go out. And the big benefit for the hospital system in developing this wasn't necessarily meeting an unmet business need, because they are not profitable in this endeavor, but it was a recruiting tool. People wanted this, and they wanted that specific training in these areas that were requiring them to be 7 to 10 years into practice before they could fulfill this. And those were the jobs that industry just could not get filled. They're wide open. So they really started to use it as a recruiting tool for top talent to get them into the system. And I put these pictures in. These pictures are actually from Monday as I went around. So they have their weekly case conference. So they've really tried to address the continuing education and process improvement course and quality improvement they offer through the ACPs. On your left, this is the Monday case conference. Every week, one of the ACP fellows from one of the many tracks will get up and present a case. And this week they were discussing aortic dissection. And as you can see, they all meet around. They go over the cases. There's a discussion afterwards. The picture on your right just happened to catch my eye, and I had to snap this. So these are the books they're using. And they are, by and large, using the same medical text that you would expect your residents or you to go out and read to prepare research for boards. This is actually a board review book. They had the big orange book that I think most of the people in ACS recognize that book as the board review book for critical care that most physicians turn to when it's time for recertification. So they're using a lot of the same materials to go through to prepare for their work. And it's a multidisciplinary conference, so you get a really broad spectrum of topics presented here. And on the right-hand side of the picture, this is Michael Gibbs, who's actually the chairman of emergency medicine. He acts as the fellowship director for the ACPs on the emergency medicine side. And just out of the picture to his right is Jaspal Singh, who's a critical care director for the health system. And then, of course, I head up the SEC portion and the SEC track. So it really gets administrative buy-in as well. And it also got national recognition. As we started to stretch this out more, specifically at level 2 centers, the residents didn't exist. So you guys here go cover traumas, provide care for those patients in a great educational setting. It's not available everywhere. So this work has fallen by the wayside. There was a huge amount of value that could be added by using ACPs. And East actually took a position statement on this and said that not only is it advantageous to do it and they can provide care, but you should really consider doing this in your institution to meet the shortcomings of care across our country. So a fair amount of value added from the situation because you're bringing in people to help provide care, albeit not needing to do full-in surgical procedures or without supervision, but they're certainly providing a large deal of billable care for the institution at a price that is not costing them as much as it would to recruit and employ a physician in a similar position. So one of the ACPs started saying, gosh, we're talking about physician burnout across the country. We're seeing people dissatisfied in their jobs, ACPs not being fully used to their talent level. Is burnout a problem amongst our group? So Megan, which is one of our medical critical care fellows, was rotating with us at the time as her QI project looked into burnout rates across ACPs. And I think this is a problem you'll see across the country, that people are dissatisfied in their job. So just as you would expect, for your first couple years of residency, you're taking on the chin, you're trying to put in the extra hours. It's a lot of logistical work going in. You can get burnt out and dissatisfied at your job. And that's exactly what she saw here. So 87.5% of the ACPs that she looked at, and her response rates were on the neighborhood of 60 to 70%. But 87.5% suffered for some form of workplace physical and emotional exhaustion. 25% could be categorized as severe using the inventory that she used. More importantly, 94% of females that she surveyed felt burnout in their job. 100% of our ACPs, this was not fellows in the program, this is actual practicing ACPs, had symptoms of burnout. And to me, most striking was the very bottom down here, that 100% of the people surveyed plan to change jobs within 2 years. And I think that speaks to the turnover and the challenges we're facing, even with an integrated program of keeping people present. Now, I can tell you, we don't see that level of turnover. In fact, I think we've had 2 ACPs leave since inception of the program 7 years ago. And we are at a staff of about 16. So nothing near this in terms of turnover rate. But I can tell you, talking to the group, there are a lot of job dissatisfiers they have that we're failing to address as an institution. And a lot of it comes from organizational strategy all the way down. I showed the picture a few minutes ago of the 3 individuals. So Dennis heads things up, but right under him with blonde hair was Brittany Broyhill. And she's actually promoted now to executive ACP. And that is a parallel model in our organizational structure and is equivalent to CMO at our institution. She reports directly to the chief physician executive on the AP side, or ACP side. So they have a parallel track from the medical group that answers around. So even though you have ACPs practicing on your license, they actually answer to a completely separate organizational structure that doesn't tie in until it hits the physician executive level. So they were really doing this to branch this out for a number of reasons, but first and foremost, so they feel they have a channel to answer to someone that has their best interests in mind, that understands the process, and will make sure that they're well taken care of. So how does your organization communicate strategy to you? And I think it's important, certainly for the residents, as you go out and start looking at jobs, how does your hospital system, how does your work, as you start out as junior faculty, how do they relate the mission to you? How do you get that tied back into your daily practice so you can be the most effective for your practice? So again, value equation will drive change in the system. Disruptors can short circuit or shortcut. So CCRU, shortcut a lot of things, better transport times, added value to system. ACPs, I would argue, are probably both. Shortcutting some work and making your life easier in a lot of ways, but at the same time, short-circuiting a process that makes expansion a little trickier, makes day-to-day workflow a little more difficult, and now with issues of burnout, is maybe causing some workforce instability as well. So finally, you need to know your organization strategy. So first and foremost, I always like this picture because when you show up at your job, or even before you show up and you're interviewing, you really need to keep in mind what type of structure of organization you work for. Are you stacked in what's called a control mode here? And this is reminiscent of the military, where you have each level answers directly to the person above them and up and up and up, right? So think about residency, right? You're going to just run it up the chain, if you will, as opposed to a flat model, which is over here. And this you'll see at places like Amazon. It's been really popularized in the last couple of years. The book Team of Teams, it really discusses this and use of special forces in this country and how they approached problems in the field, and the fact that the enemy was so fluid that if they worked through a control structure and waited for answers to come down all the way from the top, all the way back down to the bottom, the situation had changed and they were ineffective. So you're seeing businesses go a lot of times to a flat structure if they can find the right people. So you have to keep in mind, everybody has to be very autonomous and reliable to work in a flat structure. So as you stem into this, does anybody know Erlanger's mission off the top of their head? Right, I wouldn't know. Until recently, wouldn't know my own hospital's exact mission statement. But here you go. It's to deliver excellence in medical care, to improve the health status of our region while providing vital service to those in need and training health professionals through affiliation with academic partners. Mission statement of Erlanger Hospital. So if you break it down, it got the same parts that most places have. First is delivering excellence in medical care. So a really good care for people that hit your door. You want to provide the best possible care you can for your patients. And I think it's the heart of what we do with everybody in this room. And most medical centers strive, if they have one mission, they would say that this is our primary mission. But you also have a secondary mission, which is to improve the health status of your region. And this is where public health starts to tie back in. And when I think about acute care surgery practice, as much as any other practice, establishing trauma networks for the region, working on injury prevention, whether it be Stop the Bleed campaigns, education in schools, seatbelt campaigns, it really starts to tie back into trauma. And then you have an educational mission as well. So training the health professionals. And that ties back into value for me in a way that doesn't show up on the dotted line, because you're training the next generation of providers. And you're increasing the quality of the product you offer, being a training institution. And this is often lost on balance sheets and dollars and cents, but it belongs right there beside it. This is where I work. This is mission and values. They recently revamped this and streamlined it with expansion. It used to tie back a little more into just the Charlotte area. Obviously, we're becoming a multi-state institution at this point. So even the name has to change. We're no longer Carolinas Medical Center, then we're Carolinas Healthcare. Now, as of a few months ago, we're now Atrium Health. So our mission is to improve health, elevate hope, and advance healing for all. But more importantly, the vision is to be the first and best choice for care. And they're really driving this within our institution. We're asked to cut $300 million from the bottom line in terms of cost, just across the board. And they give us a 2-year window to do that. So we're really trenching, digging back in, finding ways that we can start to save the system money and provide a better product for less. But at the same time, they still want to be the first and best choice for care. And they really push it out there by promoting their service lines that are excellent. Whether it be Levine Cancer, the Trauma Center, or the Children's Hospital we have, they really push those entities in the press. And it's led to a culture that's a really great working relationship. I was surprised when I went to interview for my position. The thing that struck me more than anything else, and that ultimately helped me decide where I wanted to practice, I knew I needed multidisciplinary care for my patients, and I had to be able to get along with the other providers. So when I interviewed with orthopedic surgeons, and when I interviewed with emergency medicine, it just clicked, and you talk about the relationship. I'd never experienced a relationship anywhere else like we have at our institution. Very collegial, we work together, we overlap, and not only in terms of resident education, but day-to-day practice, and most of us even hang out outside of work. So, but it's led to collaboration projects on a national level. So we get national funding to the tunes of several $1 million a year from Metric to do extremity research, inflammatory research, looking at DVT prophylaxis in our trauma patients. We have protocols that stem across the board. They're probably pushing the lines of what you see anywhere in the country. And our pre-hospital care is tied in from the county straight into our medical center. So ultimately, you want to know, how can I add value as a resident? So first and foremost, for residents, you've got to focus on just delivering great patient care. This is your purpose right now. Learn to provide care, learn to be a general surgeon. And that will serve you better, even if you decide you're going to subspecialize into practice, because you can always fall back and remember your skill set you have and apply it to any other field that you're working in, and add value to your system. Because if things ever slow down, or there's a hiccup, or really anything comes up, one of your satellite facilities goes down and needs coverage, you're available. So it's a way for you to add value by improving yourself right now while you're in residency. Certainly mentoring, you can improve your ability to understand what's going on out there by getting a mentor. I called up John Green when I was a resident. I had great mentors here in Erlanger, but I knew I needed perspective from outside this institution because I wasn't always going to be here at the Baroness. So I started getting mentors accumulated from outside this institution to tell me what that job market looks like out there, what the trends look like nationally for where I need to go in terms of the care I provide. And then I targeted professional goals and asked myself, what is my dream job? What does the path look like to get there? And for me, that helped drive my fellowship decision. I looked and said, listen, I love the people in the Chattanooga area. I like the care we provide. I want a system similar to this. It's somewhat of a hybrid between a community program and an academic center that maintains that family feel to it. And my finger landed on Charlotte, also with talking to Green. They just had the feel there that I was looking for in a practice. So I could map out a plan that said how I needed to get there. And finally, for some of the junior faculty, some things I found so far, the ways you can add as a junior faculty. I put a picture of Dr. Scalea up here. Everyone just refers to him as the boss. It's shock. So you sit down. Again, it's the same picture I put up before. Every time you go in his office, same posture, same demeanor, everything exactly the same. But he said, in your first job, the only words should ever come out of your mouth are happy to help. And you should just be busy. You should always be available, whether it's to nursing, to administration, to your partners, whatever that is, always available, always happy to help. And I said, that sounds great to me. So that's how you maximize your value as part of the team. But also, everyone needs to work at their highest level of training. And we see this whether you're in an ACP role, a physician role. If you're not practicing at the fullest ability of what you can, if you're not pushing the line, you're not delivering the best care for your patient, but you're probably also not really fully satisfied in your job. So I go back to the start. I said, someday I want to work with someone like this. And lo and behold, there he is. You see Dr. Thomas on the right, and me on the left. Ended up scrubbed in together on a case. This is just over a year ago now. but into practice. So Brad finished up in the military, took a job at CMC about 2 years before I got there. So ultimately wound up working with two of my mentors at my current job, at Dr. Green and Dr. Thomas. We affectionately call it Chattanooga East. So I'll leave you with one final quote from Deming. And to me, this one really, as you stem out and start to pick up more administrative roles in what you do, and the weight of stuff that isn't just the joy of patient care and helping people starts to weigh on you. And administration's coming to you saying, gosh, you got to drive down costs. You got to find some way to push this line. Keep in mind, costs are not causes. Costs come from causes. I like to say that costs are the sepsis of administration, meaning that sepsis itself, while labeled an entity, is really secondary to something else. And until you get at and treat that underlying problem, you're not going to solve sepsis. So remember, costs are not causes. I'll at this point say thank you. I got a picture of my family up here, which has grown a little bit since I left Chattanooga, and then my new work family on the right. So,
questions, comments for this excellent presentation? I guess I'd start with one question. Kyle, what was the reason, if I understood your study about your pre and post ACA, what was the reason for the increase in charge? Is that what you said?
For the increase in charges. So
was that wasn't your advanced practitioners, was it?
No, it wasn't our advanced practitioners. They've been there for years before that ever happened. We originally thought, gosh, is it a trauma activation fee that goes in? And it's not. The only thing I can come up with, if you look across the board for the charges that go out, it's pretty homogenous across everything that we instituted in terms of charges that went out. And I think it's a multiplier coming at the administrative level from the hospital. And if you look at part of the ACA, there was talk when they were instituting it, they were going to do price caps in order to control costs for a period of 5 to 7 years at one point they were discussing. And right about the implementation time is when you saw that ramp up. So I think what probably is going on there is that if you say to an institution, you're not going to be able to charge any more than $5 or something for the next 10 years, if you're charging $5 now, we'll instantly jump our price up to 10 because we anticipate the cost being $10 5 years from now, and we don't want to lose revenue or lose money across that time. So it was, I think, a little bit of prospecting in terms of.
So it really came from the administrative direction, though. It came from the business office of your hospital and not you and healthcare associates.
Yeah, and I should clarify, I don't think that you saw any administrators making an active decision to charge an increased level of care. I think what you probably did was every manager that knew about that directive worked into their bottom line, whether it be for the price of a spirometer or materials is going to go up slightly because that's going to be capped. And it was just across the line. Everything crept up just a little bit in prospecting that it just kind of seeped its way into the business model.
But it probably became a business strategy for your institution then. Yeah. Okay. Now, the other question then would be, because we've heard it here in our implementing EPIC, that while it's terribly expensive to put it in, the hospital is expecting to make a lot more money because you're going to capture a lot more charges. Could you account for it in any way on that basis?
At our institution, no, because we're still with the same medical record. As terrible as it is, our institution unfortunately did not go to EPIC. We're a Cerner shop right now. And I can tell you there are at least 2 to 3 third-party add-ins that open in addition to Cerner. Anytime I open up the EMR to make up for the shortcomings of an EMR. And this is one of the leading EMRs across the country, and I think it speaks, by and large, the fact that EMR is probably not the answer to your problem at your institution, no matter what that problem is.
I think most everybody here would agree with that. But I mean, the point is we've got it now. It's sort of like a dog chasing a car. We've caught it now. How do we get rid of it? How do we turn it loose?
Well, the good news is at least you caught a good car. I will say that of all the ones I've used, it tends to be the best, both in terms of integrating in research and capturing things that go out to the administrative side.
But you don't think that the computer system could account for your increased charges?
No, I don't think so.
Okay.
In terms of upcoming across the time. So.
Go back to, because you went over it quickly, because I think everybody here, medical students and everybody ought to understand this issue about an operating loss. How do you plan to go forward with a continued operating loss? Because here, a big part of our mission right now is making money, seemingly. And so if you're operating at a loss, are you going to decide that, you know, it might be okay for those other hospitals to have trauma centers and start to share some of the bleeding here?
Yeah, that's been an active conversation, you know, the whole discussion around no margin, no mission. And, you know, how do you cost share that across the region? Because we don't receive, you know, funding for being the trauma center with the designation the way they do in a lot of states. So the way to make up for that operating loss, we discussed bringing another level 2 online to help share some of the costs. However, I think having the trauma system in place for us, even though it itself is operating at a loss, still provides value for the system because other things come along with that as well, whether it be referrals for aeromedical transport, for you know, cardiac care, transplant, stroke care, all comes tied into the trauma system traditionally at trauma centers. So I think by doing away with that, they're also opening themselves up for a big loss in other areas, and that's why even if we operate at a loss, they're still pretty happy.
Well, but you do have to accept from a business model standpoint, you have to be careful about that, though. I mean, Kmart had the blue light special, which is trauma is the blue light special at your place, and Kmart is no longer in existence, right?
Correct.
So from a business model standpoint, I guess you got to be careful about that. It would seem to me, I mean, in terms of how long it can be that way. We sold that concept, by the way, here 40 years ago, that we need to be a trauma center and take all comers, that if we took all comers, we would ultimately win. And you and I had the discussion last night about burns. We closed our burn center, which was stupid, years ago, because some years it loses, but some years it really makes money depending on what your patient population is. And it also drew other patients here. So, you know, the trauma center for a long time here was actually a profit center because we got it all, which meant that, you know, the banker who had the wreck on the interstate came here also, where for other things, they never came here. They didn't come here for thyroid surgery or gallbladder or anything else, but they started to as a result of the trauma center. So I think your point about it bringing other business to you is a good one. Anybody else have any other comments? I've got a bunch of things I can say here, Dr. Barker.
Yeah, a lot of
Wait a minute, talk with that, yeah.
Hello?
All right.
Morning.
Hey, Kyle, how are you? Good to see you. A lot of cost and loss and profit occurs actually on paper in the chief financial officer's office. And with trauma, you can either make a profit or you can make a loss depending on what operational costs you ascribe to that program. You know, when you go ascribing all the, you know, blood bank costs and pathology costs and all of this sort of stuff, it depends on how you want it to look. I mean, I've been through this before with our chief financial officer, and it depends on how you want it to look. And sometimes you make $6 million if you look at it one way, which is, you know, sort of what we've done in the past, or sometimes you can parse it out so you've lost money. That's just my comment. My question for you would be how efficacious have you found your electronic medical record in doing clinical research? I think that's a big benefit for us if we can get our Epic up and running and get a good database, that along with our trauma registry. And can you dump data from your electronic medical record into your trauma registry? Thank you.
Yeah, so I didn't address this as part of my talk. So one of the other things I picked up and being brought in, you know, is the NPH in the group is more or less their data wonk. And I, in my spare time, taught myself to code. And I picked up another language so that I can go out and mine these data banks that we have for information and start to pull the big data in. And we've actually got a group and a buy-in from our administration it's an entire gaggle of PhDs they have to help pull this data together and improve our quality monitoring systems throughout the institution. And in that, they're actually able to access we have what I consider a pretty shoddy EMR. It doesn't do well at pulling data out for research. Epic actually does a better job of mining our database to get the data out of it than our own system does at getting the data out of itself. So from a research standpoint, I think you're set up well with Epic to be able to go after that data. However, we do have the ability to go in and get that because it's warehoused on servers and we can chase it down. And we're finding more and more as across the country, people are just describing, well, big data will answer everything. And they're finding that that isn't necessarily the case. It helps answer a lot of questions if you know the question to ask. And by and large, that's what they're finding, and they're getting more clinicians tied into that group. And that's my role in the health system.
I think a follow-up point to what Dr. Barker just mentioned, though, is more of your young doctors need to do what you've done, and that's get advanced degrees in other areas that look at public health, that look at finance, MBAs, that sort of thing. So many of you have, because physician administrators will be really important, I believe, long term. And they already have been in healthcare, which we could talk a lot about, but at Geisinger and places like that where physicians had control. Carolina's healthcare system grew to what they are because they had a predominant physician board. If you looked at the one common thing, that the reason they went from the size that Erlanger was in 1980 to 3,700, 3,900 beds now, because of their board structure. Everything else about it is the same. It was the comparison for Erlanger in the study back in the 80s. Your point about your program for your advanced practitioners. As you know, during your residency, we did that here. We hired some with work hour limitations. We couldn't cover everything we needed to, so we added to the red shirts with a nurse practitioner. I said, this is not going to be a problem. They'll work at night. They'll work some on the weekends. Residents won't really be affected. And then we found out that no nurse practitioners would work anything except 7 to 3, 9 to 5.
Monday through Friday.
Monday through Friday. So do your graduates work at night?
They do, and because we build that as
graduates
an FTE,
work at night. Now, students, you can have them work, but what about the graduates?
Of the ACP fellowship? Yeah, as we hire them into those roles, the entry-level position oftentimes is paired up with a more senior ACP, and they'll work together for night coverage on the surgery critical care service, which is a big difference. So we split out our critical care in terms of trauma critical care, and in surgery critical care, we provide support for all the other services that are not trauma in the ICU and provide that critical care. And that isn't staffed entirely with physician and ACPs. There are no residents. It's a really big opportunity if we had additional residents for them to rotate there. So.
But are they mostly students, or are they mostly your
graduates?
They're
they're graduates. They're out
All right,
practicing.
so do you have any graduates that leave your program?
We do. Our hiring rate for people that leave, because they're so sought after, we only retain our specific track, I think, right around 50 to 60%. And part of that is hiring differences that headhunters come in and probably.
Well, do a follow-up study and see what they're working, though, because I'll bet they're working Monday through Friday daylight hours. But just check it and see, because I bet you that they're not working at night like residents do, which we can seem to make them do. One of the points you made that I want to reiterate for the benefit of everybody here, because it's so easy as a physician now to get your head down, knees up, and just work all the time and not go to conferences. And you find out what the rest of the world is doing if you go to meetings. And, our faculty and people here are guilty of this. I see it all the time. They don't really realize what's going on in the rest of the world sometimes. And if you don't go to those meetings, you're not going to find out. I'm preaching, I know, but I'm sorry, it's true. I think the other point I wanted to make is that if you listen to his talk, patient is at the center of everything. If you come back to those business models and strategies in healthcare, if a patient isn't at the center of it, it isn't going to work long term. So congratulations on that. Now, I couldn't help but come back to tell you all the story. I know everybody's tired of my stories, but your process control with the Caudy study, the fact that all you have to do is change one of the elements in it, and if you can get away with that, then you can make it all happen. When I was in the Air Force and stationed at a SAC base in central Indiana, you were always at threat in the Air Force of an inspector general's audit and study, except here if you have that, they're coming weeks in advance. In the Air Force, the first time you're having an IG study is when the airplane comes within the radar of the base, they tell you we have an IG team landing and we will be investigating you. So you had no way to prepare for anything. So we had one of those come in, and I was, I had an internship and went in the military. I was the chief of the clinic. We had 16 doctors and took care of all the base personnel, retired people in the area and stuff like that. So at the end, we thought we were providing pretty good care. At the end of it, the colonel, who was the head of the IG team, sat down with me and said, well, you know, it seems like things are pretty good as far as we can tell from a quality standpoint here, but you're not seeing enough patients. I said, what do you mean, Colonel? I mean, we're seeing everybody that wants to be seen. If they want to be seen, they get an appointment, they get seen. I said, well, I'm sorry, but I looked, and, you know, you're only seeing an average of 18 patients a day, and that's not enough patients. And so, you know, I think that needs to be corrected, and this could be considered a serious deficiency. So I said, well, okay, sir, we'll look into checking out that then. So we got together with physicians, and none of us could figure out how we were going to make more people come in to be seen than we're already asking to be seen. So at the end of every day, you had a patient list. Of course, everything was done by hand. You'd go out and make up names and add it to your list. You know, I saw Ted Kennedy a bunch of times, and, you know, people like that. John Wayne was frequently seen. So you added it to the list, and so sure enough, about 4 or 5 months later, you know, the IG team comes back again. Same colonel heading the thing up. He sat down with me. He said, see, I told you things would get a lot better if you just saw more patients, because we'd gone from 18 to 26 patients a day. He said, see, it's all good. I said, hey, this is great, Colonel. Thank you so much. It's been an enlightening experience for us, and we're good. So there are ways to, so when you start looking at outcomes results, then be sure you're looking to compare an apple to an apple. And that's the problem we have right now with outcomes. And I just haven't had a chance to tell the faculty and everybody, but I volunteered us to be a pilot study as an institution, not just here, but Athens and Dayton as well, for the College of Surgeons getting involved in trying to head up and move forward with quality outcomes analysis. Last week, the call came from David Hoyt and David Richardson, who you had up here, because they're collaborating now to do that. So they want a couple of institutions to pilot study. I don't know what it looked like yet, but we'll keep you informed as we go along. Kyle, it's great having you back. Great talk, well thought out. Thank you very much. We look forward to watching your progress down the line.